Welcome to Analyzing Healthcare by Scale Community, which is an education-focused organization comprising of passionate global healthcare leaders. Analyzing Healthcare is Scale's podcast series dedicated exclusively to unpacking the myths and foibles that have been directed at US and global healthcare for as long as we can all remember. Is US healthcare broken? The worst in the world? Perhaps, perhaps not. Let's find out together as we invite thought leaders of healthcare to share their views. I'm your host, Roy Bejarano. Okay, and my pleasure to introduce Senator Richard Burr to our latest podcast. Richard, hello.
Roy, great to be with you. Thank you.
It's a privilege and an honor. Someone as esteemed as yourself with the amount of time that you spent representing our country. I counted something close to 30 years in the House and the Senate combined. Does that sound about right?
It sounds about right. It's a very diplomatic way of referring to me as old.
Experienced. You know, it's hard to get experience without time. So that's the trade-off.
Well, that's exactly right. And listen, a historical foundation is important, not just for interpreting the past, but for charting and mapping out the future. And I think we don't do enough of it in this country. And we've certainly seen within the halls of Congress a great interest in purging the system of people that have the same color hair that I do. And I would only remind some that when you talk about healthcare policies that actually have a history of working, it's people with the hair the color of mine that remembers why they created it, why the structure of what they did works. And in many cases, it's the ones that weren't there that don't understand the importance of certain aspects of those. So a mix of all is important.
I think that's amazing. There's a difference between reading about something and living that something. And we still haven't bridged that gap. So no substitute for people with actual real life experience. So I definitely appreciate you saying that. I want to jump in to healthcare. And so you lived in two worlds, the legislative world and the political world. So I'd call that world A. And world B is sort of areas of focus where you took a keen interest for years and really dove in at the industry level, if you like. And healthcare was definitely one of them. So what drove you to that interest in healthcare? You served as chair of HELP, which was a healthcare committee. You drove legislation that really focused on actions that could save us from a pandemic. And this was back in the early 2000s, decades before we had to deal with COVID. So you were very much proactive about healthcare throughout your political career. What motivated that interest?
Yeah, it's very simple. 30 years ago, when I became a member of the House of Representatives, I was chosen to be a member of the Energy and Commerce Committee. And in the House of Representatives, healthcare is shared between the Energy and Commerce Committee and the Ways and Means Committee. When I looked back at North Carolina as a new member of Congress, I realized that healthcare was the largest employer in the district that I represented. So it wasn't a question of whether I had any expertise. I didn't. It was a question of if I wanted to represent my constituents, then I had to learn this issue. So I won't tell you it was easy. Many times I thought it would be easier to go to med school to get the education I needed. But I found myself on weekends coming home and scheduling myself to go into surgery at one of the hospitals, to actually be there. As we talked about cutting the reimbursements for certain procedures, I wanted to be in for a heart bypass to see in the operating room, how many people can you cut out? And I'll be honest with you, it was enlightening to me because I remember the first bypass surgery I was in, there were three people. There was an anesthesiologist, there was an OR nurse, and there was a physician. And I went back and told my colleagues, you can't cut them. There's nobody in the room that you can cut out. As a matter of fact, if I were on the table, I'd want three more people. So we ought to increase reimbursements. I won't tell you that that's the scientific way to do it, but I think there's a piece of reality that has to be brought into every debate about where we go. And, I'm still one that, as I left Congress, was still asking myself as we got ready to make a change in policy, what's the capital market impact on this? Because I recognize the fact that you can have the greatest idea in the world, but if you can't finance your way there, then it's just going to be another failed effort. So it's important that we understand that policy has to match up to where capital feels that they have the knowledge that they need to make an investment in that. Unfortunately, there's not unlimited capital, but we have unlimited innovation. And even today, probably 80% of the innovation that sits on a bench isn't going to find the capital to finance it all the way through. Some of that will be because they failed a clinical trial. Some of it will be because they just ran out of runway. Some of it will be because there are too many other attractive offers. But the two have to be in sync for there to be success.
So you spent a certain portion of your time in the House. You spent an equally significant portion of time in the Senate. And both in the House and the Senate, you were heavily involved in healthcare. Which of those two bodies has a more informed view of healthcare in this country as it actually is? Which of those two bodies played a more valuable role in shaping the future of healthcare? Is it an equal split? How do you think about it?
Well, listen, I can't judge it today versus 30 years ago. 30 years ago, the House was the most educational institution that existed in the world because every piece of policy was developed at the committee or subcommittee level. Not the case today. Bills appear by immaculate conception. A chairman and a ranking member know how they were created, but members don't necessarily know.
Is that because they're catch-all bills that cover such wide terrain?
I think
they have so many authors?
Yeah, I think in large measure it's because of the power of either a chairman or a ranking member that they want to expedite the process. And truthfully, when I became a member of the House, the chairman came to me and said, "I'd like you to reform the FDA." And that was the most exciting news that anybody could have given me. And as I told my colleagues, they sort of laughed at me because they realized the FDA had not been reformed since 1935 when it was created. So I was given a task that couldn't be done. Well, I'll be honest, Roy, it didn't happen in one session of Congress. And my partner on the Democrat side was a guy that was, he and I had nothing in agreement, Henry Waxman.
I remember.
Henry and I made a pact that we were gonna weather the storm, and we carried it over to the next session of Congress. It took us 2.5 years, but we passed the Food Drug Modernization Act, which is basically law today. It made significant changes. I'll just point out one of them. It allowed for the first time for foreign data to be used for U.S. applications to the FDA.
Very helpful.
Very
helpful. You create a lot more capacity for clinical trials.
Yeah, something that was never used until 2019-20 during COVID. So we missed almost 25 years of utilizing global data, which, you can't find a geographic area that isn't benefited by global data because nobody has this pure population of people. It's all a mix.
Also, just the infrastructure of capacity, right? Having different access points to patient studies creates a higher likelihood of completing those studies at a faster pace.
Yeah, and even just the demographic makeup of the trial might bring you to a different conclusion that's more beneficial to the overall population. But, again, I look at that as a huge initiative that I did, but it was just sort of the beginning point of issues that affect not just domestic health, but global health, as evidenced by the pandemic all hazards legislation in 2004, which was the architecture that we created a vaccine in 12 months for COVID.
So did you stay as involved? I know when ACA came out, you were heavily involved in reshaping, refining, pushing back on large parts of it. Did you do that from the Senate? Was your involvement in healthcare in the House more focused on new legislation, research, new direction for institutions like the FDA? And in the Senate, it was more about absorbing large policy and trying to refine it. How do you think about your role in healthcare as you migrated from one side of Congress to the other?
It was an attempt to try to make sure that the policy that we were putting in place had some visionary aspect to it. Even though PAHPA was created because of one H5N1 at the time and the threat, and the anthrax attack that happened in Washington, it ended up becoming the architecture for COVID vaccines to be created under. So it met the threshold of a visionary policy, a visionary architecture that could be utilized. And I think that we all know in this country that government is slow and cumbersome, and it seldom gets things right. And so if in fact you don't write it in a visionary way, then the future is only conditional upon Congress going in and changing it again and again and again. And they're usually behind the curve. So in the case of PAHPA, it's a great example where it was written in a way that it could accommodate what was needed 20 years down the road. And Congress was smart enough every 5 years to update it based upon what we learned.
So PAHPA, just for everyone listening, is Pandemic and All Hazards Preparedness Act 2006, getting the country ready for bioterrorism and natural pandemic threats. So couldn't be more relevant to what we experienced in March, February 2020 and beyond. How did that act prepare us for what happened in 2020? Do you draw a bridge between what you did back then and how the country reacted in 2020?
Well, the country, I can say this, the healthcare infrastructure immediately went to the architecture that was created out of that to structure not only how we targeted vaccines, but the clinical side of it became global versus domestic, as I pointed out earlier. I think when you look at the way that the infrastructure reacted, emergency use authorizations could be issued by the FDA commissioner versus by the president. And we learned that as we went through another domestic health incidents where children were incredibly impacted by the inability to hold down oral medication. And we really needed an executive order out of the president to allow injectables to be used, but they hadn't been approved yet. And it took almost a week to get a president to do it. And we had 7 pediatric deaths during that period because they couldn't keep down the oral medication. So Congress recognized the fact that we couldn't separate it so far that decisions couldn't be made in a timely fashion. So we actually put the authority at the commissioner's level. Right move to make, and Congress will find that the same architecture will work 20 years down the road if every 5 years when they reauthorize it, they apply what they've learned and they change it to reflect that knowledge or advancements in technology.
You know, it's interesting because human beings being what we are, our mind goes through a certain journey as we go through a crisis. I think the first port of call is panic. And then the second is strong desire for action. And usually if there is infrastructure in place, like what you personally crafted back in 2006, you get rapid action. And then hopefully, if you're lucky, the third destination is results. And I distinctly remember all 3 of those destinations. And for example, results, big difference between pre-vaccinated populace waiting on a vaccine and post-vaccinated populace. Pre-vaccinated, still very much in panic, inactive, quarantined. Post-vaccinated, liberated. Everyone's free to go and do their thing. But then there's that 4th destination that we all arrive at, which is quarterbacking, right? The post-event audit, which often leads to regret. What I find fascinating about that, and I was just having this conversation with a New York senator who's a good friend, and he was, scratching his head about all the things that were forced on the public and should we have done it? And I just reminded him that at the time he was making decisions about who to let into a theater, who has to wear a mask, who has to get a vaccine. And at the time, we were dealing with a condition that was costing lives by the hundreds of thousands, by the millions. And so you don't get the luxury of waiting a year, waiting 10 years, doing your research. You're really forced to act in a whole host of directions real time. So speed becomes the most important thing. In retrospect, you look for all that data, you look for all the confirmation, you look for optimal decision making. So I think it's highly relevant that what you created in 2006 was very focused on speed and decision making in the middle of a fog of war scenario.
Yeah, and let me add to it that two things that we built into it that I think we failed on were transparency and trust, because to move at a non-traditional pace, the public has to have trust in what you've set out to do, and that's in communications, but it's also transparency, willingness to share the data. And I think that as you look at the COVID experience, there was reluctance on the part of government to share even infection data. And you might remember the real global benchmark was Johns Hopkins establishing infection model that was out there.
We each had our own models. I built my own.
Yeah, it was no longer the CDC.
Yeah.
And this is when CDC became somewhat, in my mind, irrelevant to the debate. Then on top of that, CDC had a failure in a test that they insisted was their jurisdiction.
I'll tell you what, in a crisis, you lose trust in a second.
Yeah. And the truth is that I give a tremendous amount of credit to the Trump administration and to specifically Francis Collins in this case, because they immediately went to the technology community and said, can you overcome this testing deficiency that we had? And all of a sudden we had hundreds of options on the table.
Yep.
We still made a very tragic mistake. We should have taken the best of the technologies and partnered them with a traditional company that had the distribution network and the shelf space. And we basically said to multiple numbers of them, okay, go to the marketplace. Well, it's one thing to create a technology, it's another thing to deploy a technology.
Yeah, yeah.
And we set companies up that made tremendous investments only to allow them to fail very quickly because there wasn't a marketplace on the other side. And
I'll tell you what, that COVID 3-year period lends itself to so much research and so much learning from so many different directions. There's so much that the government, different institutions, in hindsight, would do differently. We have to be balanced and applaud all the things that were done incredibly well. I also have to always have to recognize when we're talking about US healthcare that it's 350 million people. It's not 5 million people. There's complexity in all the different states and how each governor reacts. There's cultural differences. There's political differences. And so the pressures are enormous. And every day you're losing the fight because you're losing people. So there's just so much to learn from an economic perspective. Just studying market behavior is fascinating. I mean, the amount of competition over resources, the new entrants that made unusual returns in a very short period of time for unusual reasons, the role of government in funding certain investments. I'll never get the sight of one of the government's vessels, its hospital vessel, parked outside here in Manhattan on the west side, just this massive ship that was just there to provide extra beds. There's just so much to study and dig into, and things that we would do differently next time. But that's the funny thing about a crisis. Crises are called crises because they're different, because it's not business as usual.
No, but I will say this, that PAHPA took all that into account because we had exercised everything that could happen in a pandemic, everything that could happen in a crisis. So bed capacity was one of the things we identified. I remember the day I was the most excited was the day that the Trump administration decided to distribute testing through the Postal Service. And I'm sure to a lot of Americans, they said, well, this is the craziest thing I've ever heard of. Well, we had already gamed out the delivery of Cipro under an anthrax attack.
That's amazing. That's
trying
amazing.
to figure out how do if this is a large scale thing, how do you distribute it to everybody in New York if there's been an attack on New York?
So you'd already thought about distribution, mass distribution of testing almost 20 years prior. And
20 years prior.
And I still remember when we were tracking for respirators, remember? That the big concern was, will there be enough? Then we ended up questioning whether respirators was the right protocol.
Well, and that's why global contribution to a crisis is important, because we were still on respirators when the UK had already determined that steroids were the most appropriate treatment, and we transitioned to steroids, and all of a sudden there's an abundance of available used respirators around the world.
I think that's such a huge point. When you're dealing with something global, when you're dealing with a confusing virus that no one has yet defined, it really requires a global approach before you even get to a unified response, because it's different people's experience of it, studying it real time and reacting to it, trying different treatment plans. And so that communication becomes critical. Very interesting time. And you were living through it, simulating it in 2006, 2005. So just very, very interesting how relevant that all became. So I want to bring you forward to 2010, 2011. Barack Obama is the president. He's been elected on the back of a financial crisis. He's gotten onto the back end of that, TARP and various other policies have alleviated that pain. By the way, that's a little bugaboo that I have, that everyone focuses on government spending and no one spends enough time thinking about how much of our federal debt is due to three major crises, right? Not the annual spend, not the annual budget deficit, but the financial crisis of 2008, the COVID crisis that we went through most recently, and Iraq. Those three combined represent, I think, something close to 50% of the national debt that we sit on today. So when we talk about how much room does Dodge have to really cut spending, how about we take a different approach to our crises? We take a different approach to large episodic events. You would think it's relevant. But anyway, that's an aside. Let's get back to Obama. So he shows up. He's going to revolutionize healthcare. He produces a bill called the Affordable Care Act. You're given the summary of it. Maybe you read it page to page. And your first reaction is what?
Well, I not only did I not like it, I fought it tremendously. And yeah, I did read it page to page. And I think it's one of the few packets that I kept when I left the Senate was the floor statements that I made on the Affordable Care Act. Because I thought it was very much the traditional response. And listen, I sit here today, you want to come up to this year, all the subsidies for the Affordable Care Act expire in December of 2025. So Congress has to decide whether they're going to reauthorize those. Let me assure you, from a political standpoint, when you have 435 members of the House reelected every 2 years, there's nobody going to get thrown off of their health care with everybody up for reelection in 2026. The question is, how can these subsidies be used in a way that transforms our healthcare system? And I could make a case today, and I'll probably suggest it to my colleagues, look at all the subsidy money and how you change the architecture of healthcare and ask yourself, if we change the architecture, how much money do we save the overall system, even if we turned around and gave everybody who's on the Affordable Care Act coverage in some way, shape, or form? So I'd predict to you today, nobody's going to be thrown off of healthcare. The real question is Congress going to take the opportunity to actually invest this money in a way that changes the overall consumption model of healthcare in not just America, but globally? Or do they take the easy road, which is just to reauthorize it and continue to let a system feed those folks that are on it that does or does not meet their healthcare needs?
Now you put me in a dilemma because I want to take you down two paths and they're different. I just don't know which path to pick first because they're both fascinating. So I'm going to delay as much as it hurts me because I can't wait to ask you this question. But I'm not going to ask you how you think we should restructure the healthcare industry today in this country or overseas. We'll come back to that later.
Okay.
But remember that I said that. I am going to focus you on AHCA. So as a layman in AHCA, I wasn't there. I didn't influence its design. I'm just a dude living in a country that has adopted AHCA. And so from a layman's perspective, here's what I see. And I'd love you to correct me or augment my understanding. I think I've had a lot said to me about AHCA from physicians, and I've been with physicians now full-time for 15 years, 7 days a week. My phone is always ringing. And most of them don't like it. And especially the ones who historically were doing very well professionally, income-wise, really don't like it. And they associate much lower reimbursement rates and the death of out-of-network reimbursements with AHCA. And those that do more homework believe that AHCA put pressure on the payers to fund a lot of healthcare for a lot of people that otherwise would look elsewhere for their care. And so all the doctors got paid less as a result. I think that is a misnomer. I think that is connecting inputs and outputs that aren't necessarily connected at all. I see in healthcare a bent cost curve over the last 15 years, really since 2009. Instead of healthcare growing as a percentage of GDP, as it had done for 50 years straight, from 0 to 1%, from 1 to 5%, from 5 to 12, from 12 all the way up to 17.5. Instead, healthcare as a percentage of GDP has remained flat and has actually come down a little bit in the last almost 15 years. Now that we're in 2025, it's actually 15 years. And I think that payers have been along for that ride. I can't speak to all their motivations. Maybe some of them are in bed with hospitals and they don't mind increasing premiums. I'm sure that exists too. But the aggregate sum total has been healthcare has remained flat as a percentage of GDP for 15 years, which means it's risen with inflation, but no faster. And even that's a complicated statement because some parts of healthcare have risen faster than inflation. It's just the aggregate total. So I think what's driven that, I wouldn't say AHCA has driven that. I think AHCA has tried to influence cost of care, but I don't view it as something that's primarily focused on healthcare deflation. I think what's driven that has been technology, information gathering, EMR adoption, information sharing, benchmarking, and more incentives towards quality care, less quantity of care, and more understanding of excess care wherever we find it. You know, doctors that do too much, now it's public knowledge, gets published by CMS on an annual basis. They're almost being publicly shamed. Why do you need to do 10 times more pain procedures than your neighbors? And so I think the payers are in on that, trying to control costs. AHCA, as a layman, I view as primarily the way it was adopted, not the way it was written. The way it was adopted, which I think you had a huge influence on, primarily driven towards insuring the uninsured. So we went from 30 to 40 million uninsured, or sorry, 40 plus million uninsured, maybe as many as 50 million, down to 28 million, I think the latest number is. So we really huge dent in this uninsured number. What was 15 to 20% is now 8 to 9%. And I know that even within that 28 million number, there's still plenty of noise. How do you insure for illegals? I don't know that anyone's come up with a great answer for that. So really the real number of American citizens that are uninsured is around 20 million, maybe even 15 to 20 million. And I think of AHPA as being helpful in that by creating these direct exchanges where individuals can just go and buy cheap insurance. How am I wrong? Do you view it the same way? And if that's the case, it did a decent job. It did something helpful.
Well, I think, I agree with the majority of what you said. I think that AHPA was structured in a way that allowed the insurers to create the coverage. And if you remember, there were three choices originally, and everybody migrated to what I would call the
bronze, silver, gold, right?
Yeah. And everybody migrated to the silver, which is where insurers wanted it because that was the best return for them.
It's almost like wine. Don't buy the most expensive, don't buy the cheapest.
Yeah. So it accomplished what I think the stated goal was to cover the uninsured.
Right.
The question,
pre-existing conditions, people of a certain age, let's insure as many people as we can. Sounds like a good idea.
Yeah, the question was, is this the best model to have done it in? And that's where they lost me, because I think that this did set up a system where immediately the target was, well, physicians make too much money. They're charging too much for this. We're in a phase right now where we're doing it with drug manufacturers. And that's the emergence of the IRA. Well, we're going to target the 5 most popular drugs and we're going to negotiate. There's no negotiation. It's we're going to do price setting.
Right.
And what that does is it has it has this freeze effect on capital that says, well, I don't want to be the investor of a blockbuster drug because they're just going to come in and set the price.
So you're pulling at my paradoxical strings here, and I don't know how to feel, because part of me is euphoric because I'm a huge advocate for dollars in healthcare. Healthcare, when you take the dollars away, you get the UK. And as a Brit, I get the right to say it. Our healthcare is dreadful. It is shambolic. And I know in America, we try to glorify UK healthcare. We do it from a distance. None of us would want to substitute US for UK healthcare for a minute. UK healthcare is a myth. The reality is just cut off supply. And you look at the stats, they're right there. 3-year waiting lists for hundreds of thousands of people. The number of people that suffer morbidity, mortality during a waiting list period is measured in tens of thousands. It's a large number who really suffer while they're waiting for care. We would never accept that over here. Number of nurses per capita, lowest out of the G7. We don't really have nurses. And you see it, the amount of time you spend in an emergency room. We think we have it bad over here. Try going over there. Disincentivize clinicians that are not paid a fair wage. Constant strikes, and the situation is only getting worse as the money spent on healthcare as a percentage of GDP goes up, because healthcare has been quite inflationary and GDP hasn't done quite well in the UK. So they're running out of options over there. So when you say, I don't want to cut off money to healthcare, I see state by state, those states in the US that do cut off supply by attacking the private sector end up with worse stats, right? Number of surgery centers in New York is the lowest per capita in the country. Why? There's no reason for it. It's not like we don't have the investment dollars, but the whole concept of surgery centers is not applauded in New York. You have issues in corporate ownership, right? So you see it time and time again. If you want bad healthcare, all you have to do is turn away investors. But the reason why it's a paradox to me is if you let the market decide and solve, what if you're left with sustained systemic issues that the market doesn't seem to be able to get ahead of? So I'll give you a couple. One, 40 to 50 million uninsured. And I do feel like the US government gave payers, commercial payers, all the time in the world to respond to that. Okay, ignore the illegals, focus on the citizens. They didn't. I'll give you another one. Cost of drugs. So again, the US economy has had decades to react to this this fact that drugs in the US cost 2, 3, 4, 5, 10 times more than they do in equivalent alternative markets, other countries. Hasn't solved for it. How do you deal with dysfunctionality when you do have free markets and you have problems that remain unaddressed, if not through government action, if not through government influence?
I would tell you there's a difference between government action and government influence.
I know where you're going. You're going to say sometimes the cure is worse than the disease.
Yeah. I think, it's determining what the proper role is of government. We're a tremendous financial contributor. We're not a great innovator or manager. And so it's finding the right area to make an investment in to create the incentive that 40 or 50 million people get covered, versus to design the entire thing and say, here it is. Because in a lot of cases, it wasn't that people found this unaffordable. They didn't want to be part of it. They're in that 20 million you talked about today that may be uninsured.
I think that's a great point, which we rarely mention, that a lot of the uninsured are voluntarily uninsured.
Yeah, they're voluntarily uninsured.
They're in between jobs and they're winging it.
Maybe the approach should have been to create an incentive for expansion of coverage by employers to include part-time workers than it was to create a whole new hybrid system to run in parallel.
That's interesting, especially when you consider how much work has shifted to part-time.
Yeah.
There's a lot of 1099 out there.
Yeah, the question
that's
is
uninsured.
How many would you absorb just singularly doing that? Because the challenge is, how do you whittle the pool of uninsured down to where you ultimately understand why? Because it's hard to address a problem until you get the why. And I think when we were dealing with a 40 or 50 million number, why wasn't the same for everybody that was in it? And let's just face the fact, AHPA wasn't going to solve 40 or 50 million.
And it didn't. It didn't. It solved a meaningful share, but it didn't solve all of it.
And I don't think you can ignore the fact that I will use the term bribe states into participation. It front-loaded the federal contribution. So we have, as a country and states, yet to feel the effects of the enhanced reimbursement being cut back to the 50% versus 90% that it started with. So there's a lot.
There's more cuts coming.
Yeah, a lot yet to absorb.
Look, anytime your country relies on your government and your government's ability to tax as the primary driver of income for your clinicians, hold on to your horses, because what you're going to see is worse care. And
the other thing is, I don't think we've taken into account how many.
But that message is confused by other macro factors. So you might have a single payer in a place like Japan, but then you have low obesity rates in Japan. So the whole conversation of healthcare is confusing, because we look at end outcome stats like life expectancy, and we say their healthcare industry is better than ours. They live longer, the Japanese live longer. And then we associate funding models with that, and we critique our own. And so the whole thing is confused, because our model, I'm arguing, is the best in the world. Our health stats are not the best in the world. But I don't know that a hospital has too much to do with obesity. It's a thin connection.
I'm sure we will get over to talking about nutrition when we get to maybe nominees of the president. But
nutrition is a big topic. It is. And certainly every doctor out there, I know the argument is that, doctors love sick people because that's their business. I've never met a doctor that loves sick people. Doctors like to make the country healthy. They are engineered to want to treat and care and see health. That's a win. So I think most doctors would actually appreciate, being revered as being best in the world and actually treating truly sick patients that are dealing with disease and living in a country that really takes good care of itself before it even shows up at the hospital. And it's not to say that millions don't in America. Of course, millions do. But for every additional million that comes off obesity or high weight, I think you'd probably see a big sigh of relief from hospitals that are overstretched, from doctors that are, not able to book enough patients because they're overstretched, from nurses that are difficult to staff because they're overstretched. So the whole system breathes a sigh of relief when the health of the country goes up.
Well, along this path that we've been going down, you had a period of time where self-insured companies were a model that were tried.
Yeah.
And I think there certainly would be exceptions to this, but I think what the self-insured model figured out was that even when you went to your own workforce and said, if all of you try to lead a healthier life, it's a lower cost for everybody. There wasn't the incentive there for people to do that.
Yeah. We had a long podcast last week with Dr. Katz, David Katz, who is considered one of the experts. He's been a visionary on what drives health in America and the world for decades, and was very early on pushing back on carbs and the wrong kind of carbs, on saturated fats and on processed foods. And so I think his argument is supply and demand, right? You have to push on education, and there's a lot more education to come. There's a lot more awareness to come. Just because he might be reading white papers and research doesn't mean everyone is. There's a lot of that education will come in labeling. Can we label our food well and loudly? But a lot of it comes in supply as well. The supply side is the regulation. Can we get our regulators to accept that certain chemicals don't belong inside of food? And I think they're willing and able if we can get the right information in front of them as well. Or maybe that's naive on my part. Maybe government is, full of lobbying efforts that are happy to look the other way. But I'd like to think that we can rally around good decisions, as we've done for hundreds of years in this country.
Roy, my staff knew that I had one rule for legislation. When they came in and proposed it, they had to show me the human face behind the issue. And because I had to find
I've been told that you senators, you like human faces.
Well, I had to have the association with who's impacted by it to become passionate about it. And if you're not going to become passionate as a member of Congress, you're never going to stay with it long enough to get it done. And I think therein lies a lot of the problem right now, is that we're influenced by so many different things in Washington. We're not necessarily focused on the things that we should be. And that's why, quite honestly, I appreciate the fact that we're going to have some real out-of-the-box likely secretaries of agencies, that they're going to go in and look at how they redesign something that's been in place for 60 years and say, does it need to be like this anymore? That they're really focused on how do we bring in new talent that, when I got out of Congress, somebody asked me, well, you haven't had a doctor in town for 30 years. What are you looking for? And I said, I'm looking for somebody about 34 or 35. I don't care whether they read the medical journal. I want them to have just freshly come out of school and practice for a few years. Because you want somebody that you know is up to date. And we have to allow healthcare to evolve as technology and education permits us to. And I think, quite honestly, we're headed into 20 of the most exciting years as we begin to see AI specifically offer us new alternatives for drug discovery, for clinical work, for clinical data, as we absorb a database that's global versus just domestic, as we see where technology helps us to reduce the time, gives us greater reliability. Just think about it this way. Today, on the day that an application goes into the FDA on their own could turn to a database and test a compound that would tell them whether it has any safety concerns like toxicity before the applicant ever does any clinical study on it. Well, you eliminate that, you automatically are at phase 2. You've shortened the period of time that an application takes for review. You've also eliminated a lot of costs that went into it because you as an agency were willing to do the work. And it's a matter of hours or days. It's not years.
I think we're sitting in the most interesting and exciting time for healthcare that we've ever lived in.
Yeah.
And I see every day the ways that new AI, learning language models, and other forms of AI are impacting how we do things, from clinical research studies that are accelerated, the ability to analyze data, much more data, and come at much more interesting conclusions from that data, greatly enhanced, the ability to deal with labor shortages, which has plagued healthcare forever. Healthcare can't employ enough people. Today in the US, largest employer, 17.5 million people. And believe me, if we could employ 30 million, we would take them. It's just a question of cost. There is never a shortage of work to do in healthcare between the clinical and the administrative, and just the complexity of all those SKUs and all those people needing care now. Everything is urgent in healthcare. Everything is urgent. Nothing is, I'll get it to you 6 months from now. Oh, it's a month delayed. Don't worry about it. Everything is now. And just the science of it is mind-blowing. So we couldn't, I mean, it's basically traveling to Mars every day is the reality of healthcare. So we couldn't employ enough people. And that is an issue. It's great news if you want a job, but it's an issue because people are expensive and there's a shortage of them. So AI showing up and substituting or adding in areas like patient communications, right? Patient billing, patient scribing, patient oversight and coordination. These things are greatly aided because all of a sudden we do have 30 million people and we can afford them because 15 million of them are really AI technology substitutes, in theory at a lower cost. The model falls apart, by the way, if the energy expense skyrockets or if some other expense attached to AI skyrockets. Then all of a sudden we're back to limited resources. Hey, I'd love to buy this AI tool, but I can only afford so much because I don't see reimbursements climbing at exorbitant rates anytime soon, right? The government is dealing with $35 trillion of debt, and payers follow the government's lead when it comes to pricing healthcare. So I think everyone's quite satisfied with 17.5% of GDP. No one's pushing for 18.5% of GDP. If anything, we actually probably want to end up around 15%, 2 points more than the Germans, and we're happy paying more money for our healthcare than the Germans do. But I think we're sort of tapped out in terms of how much we want to spend on a relative basis. So yeah, all eyes are focused on technology as, you know, the savior of the day in terms of driving more care at very reasonable cost. That is exciting because it might actually happen.
It is exciting, and you know, one thing that we know today is that it's much more expensive to maintain disease than it is to cure. And what AI allows us to do is to potentially enter an era of cures, but it's extremely costly.
Yeah,
So,
that's so well said. So well said. We haven't had that many cures.
Starting that debate now as to how we're going to finance that, because
cure Alzheimer's, cure diabetes, cure cancer.
It's going to require a contribution from government, a contribution from insurers, a contribution from the innovator, the actual person that developed the cure, and without, and probably the individual as well. So there are going to be 4 funding components. But our healthcare system has never thought about bringing those 4 together and saying, how do we make this work? But I can show you the math. If you take an 8-year-old who has sickle cell and you cure them so that they live throughout their lifetime without the impact of the disease, you've saved money, even with a $2 million investment up front.
Yeah.
And listen, insurers get this. They understand it. We saw it when insurers at one point, when they created certain insured models where they hired a majority of the registered nurses in the country because they wanted to triage the sick patients and manage their care. So it was the managed care model. they controlled costs then. But at some point, enough of the system broke down that you couldn't maintain it any longer because you needed to scale up.
Yeah. Part of the issue we have with ACOs, going back to ACA and the funding of these ACOs, which really came out of ACA and CMMSI. And we're going to have one of the deputy directors of CMMSI on, Liz, later this month, Liz Fowler. And so this innovation group really created value-based care, which on paper makes a lot of sense and has led to wide adoption. I think there's 50 million patients flowing through ACOs right now in America. We went from 1 or 2 ACOs to almost 1,000. So this was a whole industry that was born of coordinated care. Mm-hmm. But one of the major issues of it is understanding how much data you're asking for, how much data needs to be cleaned and coordinated, how much human behavior needs to be coordinated around coordinated care, and how many people need to be involved in administrating the coordination. And before you know it, you're creating a lot of inflation, and you're creating actually a lot of bottleneck because the scaling of that is incredibly hard. And you see it in the output. What's the output? You know, Oak Street and Kano and all these groups, Bright Health, that went public losing $100, $300, $500 million a year, and went public in a desperate attempt to try to find some cheap public capital. You know, we're the future of healthcare, and suffered as a result, because anyone who relies on cheap capital learns the same lesson. Cheap capital is only around for a certain period of time. Yep. It's not forever. And so on paper, it makes great sense. But again, it sort of misjudges how scarce labor resources truly are in healthcare, because everyone is expensive in healthcare. Because healthcare is local, right? It's very hard to outsource it. You're not really getting a lot of US healthcare through Chinese labor. It's all mostly US labor, give or take call centers and billing. So technology substitutes for labor. I'm going to make a bold statement that AI in healthcare will be the most important industry that AI touches.
Oh, I think you're right. It's going to be the epicenter. It's not, but AI is going to penetrate every sector of our economy.
For sure. But do we really need our cars revolutionized like we do our healthcare industry revolutionized? Yeah. But, you know, healthcare has been waiting for this moment. So looking at ACA now, 20 years later, 15 years later, any elements of it that you think was successful? Was it an abject failure across the board? Or do you sort of piecemeal elements? And also take great credit, by the way, for what you prevented from happening. And this is the reality. ACA today is not the ACA that was presented to you, right? What was presented to you was a fast track runway to a single payer system. Yeah. Let's Cadillac tax the living crap out of everyone. All payers, all commercial policies out there should face an ever higher tax. Let's penalize anyone that doesn't go down this path and purchase this product, right? Remember the mandate on individuals, either buy this policy, and this is one of the big issues the courts had, which is essentially that's a new tax, right? That's not healthcare reform, that's tax reform. And so the idea was to make commercial policies that were much better than direct ACA policies seem ever less appealing, because they're ever more expensive with this added tax, and essentially drive everyone into this ACA government-funded alternative. Am I right in saying that? And I know all of that was rejected. So we ended up with a hybrid version of ACA that was actually quite mild in many respects. Am I right in that description? And if so, how do you view ACA today?
Yeah, I don't think you're wrong. I think ACA today is in existence because there's no alternative that's been created. In a perfect world, I think I might have taken the 40 million uninsured, and I might have taken the Medicaid population, and I might have brought them together and created a new product that was managed at the state levels, that had certain requirements to it, like everybody was assigned a primary care physician. The primary care physician was your entry point, and they managed where you went and why you went. there have been several opportunities to change that model, and no states adopted the initiative to do it. And this would have been a perfect opportunity where you could have brought them together, and the scale of what you had was enough that you could then figure out how you dialed it up or down from a standpoint of cost and, more importantly, value. But you know what concerns me still today is how much we pay in healthcare cost with no change in outcome. And I know that we have a penalty system inside of Medicare to some degree, that if you're discharged from the hospital and you come back as a Medicare patient,
the readmission rate.
Yeah, the facilities have costs for that. We'll never get anywhere under a penalty system. We will only get there if we create the right types of incentives for people to adopt what works. And that's why I'm hopeful. I'm not optimistic, but I'm hopeful that as Congress looks at this pot of subsidy money and says, should we use this for something else, that there's an opportunity really to transform that healthcare world of the Affordable Care Act participants and potentially others. Because listen, why were we advocates? Why was I an advocate for Medicare Advantage? Because Medicare, traditional Medicare, needed something to compare it to. And in many cases, Medicare Advantage, it's attracted over 50% of the population into it.
That's really interesting. So Medicare Advantage is systematic competition, right?
Yeah.
As opposed to sort of random competition. It's manufactured competition for Medicare. And I never heard that said before.
And many people choose traditional because they don't want to change. They want it simple. They want to know.
Yeah, they like fee for service. They like optionality. They don't want a closed network.
And so it behooves us to try to create an alternative for everything, because if you can't compare them, you don't know what's better. And we should be moving in the way that we find has a better outcome.
That's one of the beautiful things about America, and I want to build on this topic, is variety, variance. Before you've even gone out of bed as a senator, you have 50 states that are doing what you're thinking of doing 50 different ways. And they're all touch and feel from you. They all speak the same language as you. You can hop in a car or a plane. You can go hang out with their local representatives and talk to them about their method, whether it's Massachusetts healthcare or it's Florida healthcare. You've got 50 different case studies before you've even shown up at the office, just to explore and examine. And I think that's wonderful, because healthcare, confusing as it is, you want to study the employer marketplace. You want to study Medicare Advantage. You want to see what it means to fund an extra X million or $1 billion into Medicaid to see what happens, right? You want to play around with alternative reimbursement models. And it really is, there's no single, this is one of the horrible things about the single payer system, is innovation comes down. One of my favorite stats for US healthcare, and I'm building this huge library of US healthcare stats where we lead the world. And it's a very, very long list, except no one talks about it. For me, it's easily the most important KPIs. One of them that I love the most is number of healthcare startups. Which country in the world do you think has the most healthcare startups?
I would hope it's here.
It's definitely here. Which country in the world has the most healthcare tech startups?
I would hope it's here as well.
It's definitely here. Which country raises the most amount of money for healthcare tech startups and healthcare startups in general?
It's definitely here.
It's definitely here. So we should be proud of that, because our industry globally, our global healthcare industry, needs startups more than it needs the World Healthcare Organization. And I know that's a loaded statement, because the WHO does amazing things, but it is a statement born of the appreciation for innovation and industry and experimentation versus government bureaucracy. And it goes back to your statement: what do bureaucracies do well, and what do they typically not do well? Well, innovating new product and testing those products in the marketplace, failing and then starting again, that's not the essence of government nor government representative bodies, right? What they do well is more bureaucratic and more administrative and more oversight orientated and research oriented and regulation orientated. And they do that better than anyone. That's why companies don't rule countries. But if you're looking for better ways to provide healthcare, surely you want a lot of startups to go with that.
Yeah, and I would also add to that, if you were challenged to design the perfect healthcare delivery system today, could you do it with the state and federal regulation requirements that are in place? And the answer is probably no. I mean, we've got the systems that we've got based upon what regulation has forced them to do over time. Imagine what would happen if we started with a clean piece of paper.
Oh my God, total chaos. I don't know.
But what role does Washington have?
You have to re-educate 17.5 million providers, clinicians, administrators, and then another 350 million patients. It's not a small job.
It's not a small job, but the question is, what role does Congress serve in the regulatory structure of you've got to do this in healthcare? That, for every other product, that's me. I'm a consumer. Those are the questions I ask, and when somebody fills it, I buy.
Well, back to your example of you being a patient, one of the nice things about healthcare is we get to theorize all we like, and we get to draw up white papers and make suggestions, and we get to, in my case, do a lot of consulting. That's one of the things that Scale does a lot of. But there's no substitute for being a patient.
Oh.
And we all get to be patients. So
and we routinely ignore patients.
Yeah.
From a standpoint of their thoughts and their experience and their suggestions.
Yeah. I want to go to the question of money. So Medicare is bankrupt. Medicare is unsustainable. Healthcare is unsustainable. Healthcare is broken. These are the terms that are thrown around by the average pundit. I saw a Jon Stewart interview of Mark Cuban. This was just a few days before I interviewed Mark Cuban. And I had a conversation with Mark about this. I challenged him in his response to John, where they both agreed, didn't spend a second on it, that healthcare is broken. Irreparable, I think was the term that they used. Irredeemable. I don't blame them. These are the headlines that journalists have been feeding us for decades about our own system, US healthcare. And then you look a little bit deeper, and actually Medicare is bankrupt, but in 10 years' time, 2035. We've actuarialized the exact date when Medicare runs out of money. And so you sat on HELP, and you were the chairman of the healthcare committee, and you dealt with the budget committee, the finance committee. And how did money and funding and affordability factor into the average legislator's mindset when you thought about US healthcare? And the reason why I asked the question, it seems like an obvious question. Well, we all agreed that we're running out of money and it's crisis. I'm not sure that that's what the insiders actually think is happening for US healthcare, because as I look at the actual mechanics of it, Medicare is a tax. It comes out of payroll. And as payroll grows every year, so does Medicare revenue, right? And Medicaid is interesting because it's federal government funded, but it's also state funded. All these things are taxed in interesting ways. And actually Medicare was in surplus for decades and used to fund the government, which is why the government today owes Medicare many hundreds of billions of dollars in unpaid loans, which you assume will be paid as long as the dollar is still worth something. And so is Medicare bankrupt? Can the government not pay for healthcare? Are all the doctors going to be out of business in exactly 10 years' time? Or are we creating a headline story there where the truth is a little bit more nuanced than that?
In the eyes of American elected officials, no, because the way Medicare was structured, the government can supplement and fill the gap, and most believe that government will. Exception to the rule: government cannot fill the gap on Social Security. Social Security was written to only be on the backs of the contributor.
Right, the Social Security tax.
So that's why
assigned to the individual based on their contribution. Yeah,
that's why there's always a need to go in and fix Social Security. If not, the way it's written, you would throttle back in 8 years, I think is the number. And we would
or
get
maybe change retirement ages.
Yeah, we would get 70% of what we thought we were going to get, because the government can't dump money into it to fill the gap. That's not the case with Medicare and Medicaid. So,
but I think most pundits don't appreciate that Medicare has been lending the government money through excess. That would shock a lot of them.
At a predetermined rate of return, which is nominal.
Yeah.
Yeah.
Loose use of the word lending.
Yeah.
So how did you work with, when you introduced new healthcare policy and you led to additional funding for pandemic preparedness, additional funding for biomedical research, new drug discovery, additional funding for veterans care, lots of additional funding, but I don't think that came out of your committee that you chaired. I think that would have worked. You would have been working with the budget committee and I forget the term for the assignment of funding to different causes, right? There's a verb that regulators use regularly. Forgive me, this escapes me. Appropriations.
Yeah.
Right. As I lean forward, my memory dropped the word.
It's appropriations.
How did you deal with the appropriations committee? Do you have to, when you talk about healthcare funding, government funding, do you have to start at square one with your neighboring committees, appropriations and budget, and convince them that your cause is worth funding? How does it work?
Yeah, the short answer is no, because each committee has a jurisdictional responsibility. In health, we had jurisdiction for everything that was not Medicare and Medicaid that was in healthcare. Finance committee has Medicare and Medicaid because of how the committee jurisdiction structured. At the end of the day, though, your bigger question was, how does it get funded? And it only gets funded by the appropriations committee. So it has to be a very compelling piece of legislation to be funded. And we've had many pieces of legislation that become law, but they're never funded. So there's never been a program for. And I think going forward, all of a sudden you see that if you really want to execute change, it has to be a partnership between the Committee of Jurisdiction and the Appropriations Committee. If not, appropriators may just continue to fund the existing structure, and whatever you did from a policy standpoint never gets implemented.
So it is interesting that it's treated that way. I'll take care of the FDA, the NIH, the CDC. I'll take care of Veterans Affairs, the VA, but you go take care of Medicaid, Medicare, and let's never speak again. When you think that there's a lot of rich information in all those institutions, there's a lot of overlap and codependency between those institutions, right? The drugs that get developed by the FDA get utilized by Medicare. And by the way, that might speak to one of the issues regarding negotiating of drug prices, right? Medicare historically has not negotiated, and only now in the last few years is allowed to negotiate some, although you would argue they're not negotiations at all. There's just price fixing, which is not great.
And I would say to you, just like you described the future of AI uses, imagine if you used an AI algorithm to determine what the appropriate reimbursement is for a newly approved drug based upon the historical cost of what it treats.
Oh my God, at least 1,000 federal government bureaucrats would go out of business.
And for once we would have an accurate depiction of what the correct reimbursement amount was. And we're not talking about a tough algorithm to write, because the data exists, historical data exists to be able to load into a system where it would be instantaneous to get a coverage code.
That is interesting. So the whole concept of how we price for care, which historically has fallen under these acronyms, RVU, and is it DRG for hospitals?
Yeah, DRG.
Which is entirely man-made. By the way, so is AI. But the funny thing about AI is it takes learning to another level, higher IQ. but it might come back to us with its own new acronym for pricing healthcare. It probably will. Think about it. Someone's going to feed in a ton of pricing data into an AI algorithm, and it's going to spit out, oh my God, you guys have been pricing this completely wrong for 100 years. This is what this podiatrist should get paid for the following podiatry procedure. And we'll say, oh my God, we have been doing it wrong. So I think that's minutes away. We're going to have to come up with a new acronym. AIR, AI reimbursement, AIR. We just invented it, you and me.
And then the other thing in the healthcare system is, in an existing revenue stream, how many people take something out of that revenue? And that's something we've got to look at. That's a whole debate now inside of Congress on PBM reform.
What do you think of the coming PBM reform? Because President Trump has pointed the finger at PBMs as the nemesis of all things good in US healthcare. They're the reason why we're overspending. And by the way, as a layman, it does look pretty bad for PBMs. I mean, we have been spending a lot on drugs, the same drugs that could be purchased across our borders for a quarter of the price. And if there's one thing that Donald doesn't like, it's being a sucker. So I think he means it. This is one that he's not going to let go of. Is he wrong?
Well, listen, I grew up when drug pricing was determined at the average wholesale price plus 6%. That 6% was the profitability on it. And when PBMs were taking a slice of 5% or 6% to manage formulary and to determine what the appropriate drug was in that formulary for the categories, made a lot of sense. They're at 30-some% now.
And still using the term percent, which means if the denominator goes up, the numerator also goes up.
Yeah, and the discount rate or the rebate rate isn't the sole payment now. There's other fees that they're trying to acquire. Were I in the industry, and I've suggested this to companies, negotiate directly with hospitals. Cut out the people that are negotiating it. I mean, if you've got to create models that give you comparisons.
This is the Mark Cuban cost plus business. This is why he's so excited about it.
Well, but that's where we started.
He's not using these middlemen at all.
And it's fine to do that. It's to some degree impossible as you pool a lot together, because there's no two people that are alike, therefore they don't take the same thing. And to some degree, it doesn't take into account that my body may not handle Zocor like it would the alternative, and I need that choice. They're things in the healthcare system that are not. They don't replicate the rest of the economic models that we have. They're variables that come into play. And I appreciate Mark and others who are taking attempts that say, well, you can just do it this way and it'll save a tremendous amount of money. Answer's probably right. Will the health outcomes be the same? Don't know. And we have to be more focused on outcomes in this country than we do on inputs. Because outcomes are all that matters. Do people get well? Do people stay well? And stay well may be an input. If you can get that far down. But I think our system demands to be redesigned. And unfortunately, we're not even talking about a redesign.
No, I agree with that. I think it's helpful to take that thought and talk about how our regulators actually arrive at decisions. So the thing about healthcare is it's actually huge, right? Call it a $5 to $6 trillion spend here in the US. That's larger than most European countries. Actually, it's larger than all European countries. Maybe Germany is the exception. I haven't looked at Germany recently. But it would certainly make it one of the top 5 largest economies in the world, just our US healthcare spend. And the pieces that constitute it are confusing, right? Even within healthcare services, are we talking about highly inflationary hospital expenditures? Or are we talking about actually quite contained, in many cases, deflationary physician expenses, professional fees versus facility fees? If we're talking about payers, are we talking about employer insurance? Are we talking about Medicare? Are we talking about alternative forms of insurance like the VA or workers' comp or personal injury or Obamacare, direct exchange? Anytime you go down this path, you have a whole different ecosystem of issues to deal with. And before we fix them all or fix any one of them, what's in the mind of our regulators? And what I see as a layman again is a lot of pre-existing bias and conclusion, and then the need to find a seeming fact to fit into those conclusions. So self-reinforcing bias. And so ideological agenda, the politicians that speak on behalf of non-profit care, right? Single payer, which is really another way of saying government funded, and government delivered, ultimately, care. And then the other side is free market, for profit, and then you have the moderates in between. But what scares me much more than that is who is everyone listening to? And so from your experience, I read a MedPAC report that was requested in 2019, and it was issued in 2021, 22 to Congress on the question of private equity in healthcare. It was woefully disappointing as someone who's worked with hundreds and hundreds of private equity-backed healthcare companies. There's areas for improvement. Some are better than others. Some have better outcomes than others in terms of where the company ends up. But it had no relevance to the report that was issued to Congress. I mean, it might as well have been like a different planet that was being described. It was thin. It was presumptive. It was very weak on analytics. It didn't ask any of the right questions. And so what scares me is, and it's a question for you, did you trust the third-party research? And I guess it all gets bundled as lobbyists. I'm not sure if that's accurate or not. I don't know enough about the way the system works. But someone is feeding our politicians questions and answers. Did you always find that that was at the highest level? And if it wasn't, maybe we start by addressing that before we push for more change from our regulators. Are they really getting the best information out there? So I'll give you an analogy, the presidential choice. And I heard this the other day, the way to influence presidents is not to tell them what to do, but to give them 3 choices, all 3 of which suit your purposes. And they'll choose one of the 3, they won't go looking for the 4th, 5th, and 6th. So I sort of fear that scenario for us in healthcare, that all 3 choices are flawed.
Well, if you notice on several occasions, I've pointed to competitive models that I helped create.
Yeah.
Because competitive models
and global models that you're particularly interested in.
Yeah, give you real-time data. I was enamored at one point with the Swiss healthcare system because I thought it was potentially superior to what we had.
It does score very high in a lot of KPIs. This is true.
And in most cases, I always came to the conclusion that it worked and it was superior, but it wasn't scalable.
Yeah.
Because we've got so many things in the US that
we're never going to be Switzerland. I got bad news for you.
Yeah.
Sounds great. They have beautiful mountains.
I'll give you a story just very quickly because I know we're probably getting close on time. But under President Bush, he created a program for treatment of HIV/AIDS patients in Africa. It was called PEPFAR. And it was a very unique program. It was designed differently than any foreign aid program had ever been designed.
Extremely well funded, right? I think I remember that story.
Extremely well funded.
Yeah.
It had one person who worked it per country. One. And so the responsibility was on that one person to prove the metrics. And metrics could only be designed to say how many people got treatment. because if they got treatment, we knew what the outcome was. So Tom Coburn and I, a former member of the Senate, a good friend, Tom and I, we were great fans of PEPFAR for a reason. One, it was the right thing to do. Two, in the US, we could have saved $17,000 per year if we gave every HIV positive patient the 3-drug cocktail free, because we would have kept them out of the emergency room for 2 very predictable visits, one for retinal infection, one for pneumonia, every year. And we went to our colleagues and we said, hey, we got a way to save $17,000 per patient on an annual basis. And we didn't have a member that supported our initiative. Now, not only was it compassionately the right thing to do, it saved tremendous amounts of money. But even liberals wouldn't sign on to something like that. In every case, it's not necessarily the conservative approach that's the right one. If you can make the fiscal argument of why an investment saves money over the life of an individual or over the annual budget. So it gets back to a question you asked me earlier. What influences your decision as a member of Congress to do policy? Unfortunately, our system in the United States is influenced by how much money have you made available for us to do healthcare policy by. So at the end of the day, it's not the interaction of committees that alters the policy. It's how much money can I get in here, because the likelihood is I've got to show on the backside the budgetary score of it. So I've got to find the savings somewhere to do this. The savings were always, Roy, the subject of the reimbursement cuts to physicians and to facilities, because we were using, Congress wanted to use that money to create a new benefit.
It is interesting that the conversations, and we'll wrap it up, but it was absolutely, it was wonderful in so many ways. We covered so much terrain, but it does seem to me that we seem a bit myopic at times. And a great example is saving healthcare at the government level always involves the use of the word and the heading cuts. What are we cutting? What are we cutting? What will Dodge cut? Well, they can't cut Medicare. Trump said we're not cutting Medicare. When do we balance that word cutting with investing? Investing. What are we going to do differently? What are we going to do better? And the history of this country is born of the success we've had investing, not the success that we've had cutting. Cutting is good. Investing has always outperformed cutting. I'm going to leave it there. Senator Burr, Richard, my friend, very grateful for your time and really appreciate this conversation.
Roy, great to be with you today, and thank you for the effort that you're making at education.
Hopefully it leads to a lot. Thank you.